It starts in the morning usually, thoughtful. You wake up and there's this pressure, low, deep, somewhere below your belly button, and you think, okay, today's the day. You head to the bathroom, you sit down, you wait, maybe you push a little, nothing. So you get up, go about your morning, and by the time lunch comes around, that pressure hasn't gone anywhere. If anything, it feels heavier. You go back, you sit again, you strain harder this time, and something feels wrong. Not just stuck, wrong. There's a fullness that no amount of effort seems to touch, and a strange ache that radiates up your back and down your legs, and you start to wonder if something is really not right in there. By the third or fourth day, you're not just uncomfortable. You're scared. You haven't had a real bowel movement in days. Your stomach feels like a tight drum. You've lost your appetite. Maybe you've noticed a little watery discharge, and that confuses you because you think, well, if something's coming out, maybe I'm fine. But a quiet voice in the back of your mind whispers, this isn't normal. Something is stuck, and you don't know what to do about it or who to call or whether this is something serious enough to go to the emergency room. If that sounds familiar, if you've been there or you're there right now, pay close attention to the next 18 minutes. I'm Dr. Alex Carter, and today we're talking about fecal impaction. Stool that becomes so hard and compacted inside the rectum that your body simply cannot pass it on its own. It's one of the most distressing and least talked about conditions affecting older adults. And by the time this video is over, you will understand exactly what's happening inside your body, why it happens more as we age, and precisely what to do about it, step by step, in a way that most doctors never take the time to explain. But first, where are you watching from today? Drop your city or country in the comments below. I read every single one, and I love knowing who this community is made of. Let's start with the basics, because understanding what's actually happening inside your body changes everything. Your colon, your large intestine, is essentially a long muscular tube, about 5 feet long, that moves digested material from your small intestine down towards your rectum, where it waits to be expelled. It does this through a process called peristalsis, rhythmic, wave-like muscle contractions that push things along. Think of it like squeezing toothpaste from the end of a tube toward the cap. Steady, progressive, rhythmic. Now, as stool travels through the colon, your body absorbs water from it. That's normal. That's supposed to happen. But when stool moves too slowly, when transit time slows down, your body keeps absorbing water from it long past the point it should. What was soft becomes firm. What was firm becomes hard. What was hard becomes dense and dry and compacted. By the time that stool reaches the rectum, instead of a soft, formed mass your body can expel with reasonable effort, it has become something closer to a dense plug. Sometimes the consistency of clay, sometimes harder than that, wedged inside the last few inches of your digestive tract. And here is the thing about that plug. It doesn't just sit there quietly. It creates pressure on the surrounding tissue, on the bladder, on the nerves in the pelvic floor. It stimulates a constant feeling of urgency, the sensation that you need to go, without allowing relief. Your body keeps sending the signal, but nothing moves. This does not happen overnight. Fecal impaction is always the end result of a gradual process, sometimes days, sometimes weeks of slowing transit time. It builds quietly, which means there's nothing shameful about finding yourself here. This is a physiological event, not a personal failure. Now, why does this happen so much more commonly in people over 60? There are several very specific reasons, and I want you to understand each one. First, muscle tone decreases with age throughout the entire body, including the smooth muscle that lines the colon and drives peristalsis. Those wave-like contractions that move stool along become weaker and slower as we get older. Transit time through the colon, which in a younger adult averages about 30 to 40 hours, can slow to 60, 70, even 100 hours in older adults. More time in transit means more water absorbed. More water absorbed means harder stool. Second, fluid intake tends to decrease with age, and not always because people are being careless. The thirst mechanism itself becomes less sensitive after 60. Older adults genuinely feel thirsty less often, even when they're dehydrated. Less fluid in the body means less fluid available to keep stool soft. Third, physical activity decreases, and this matters more than most people realize. Movement is one of the primary stimulants for intestinal motility. Walking in particular activates peristalsis directly. When mobility decreases due to arthritis, post-surgical recovery, chronic pain, or simply a more sedentary lifestyle, the colon slows down with it. Fourth, Medications. This is a big one. Opioid pain medications are the single most common pharmaceutical cause of severe constipation and impaction, but they're not alone. Iron supplements, calcium channel blockers for blood pressure, certain antidepressants, antihistamines, and antacids containing aluminum can all significantly slow gut motility. Many older adults are managing 4, 5, 6 medications simultaneously, and the cumulative effect on the colon can be profound. Fifth, pelvic floor changes, particularly in women after menopause, can alter the mechanics of defecation itself, making it physically harder to expel stool, even when it reaches the rectum. This is not your body failing you. This is a biological reality that nobody warned you about, and understanding it puts you back in control. Now I need to spend some real time here, because fecal impaction is genuinely one of the most misread conditions in older adults. The symptoms are counterintuitive. They disguise themselves as other problems, and acting on the wrong interpretation can make things significantly worse. The first symptom that confuses people is liquid stool seeping out. I cannot tell you how many people have called a doctor or gone to urgent care convinced they have diarrhea, when what they actually have is a fecal impaction. Here's what happens. The hard mass in your rectum acts as a dam. Liquid stool from higher up in the colon has nowhere to go, except around the edges of that blockage. It seeps out as watery discharge that can look and feel exactly like diarrhea. The dangerous wrong action people take is to treat it as diarrhea, taking loperamide, which you might know as Imodium, to slow things down. That is exactly the opposite of what you need. It makes the impaction worse. If you're experiencing what seems like diarrhea but you haven't had a proper, formed bowel movement in 3 or more days, stop. Do not take anti-diarrheal medication. Read this as a warning sign, not a stomach bug. The second confusing symptom is back pain and leg pain. The rectum sits directly in front of the sacrum, the triangular bone at the base of your spine, and the pressure of a significant fecal impaction radiates outward into the lower back and can even travel down the legs along the sciatic nerve pathways. People assume they've pulled a muscle, or that their arthritis is flaring, or that they've been sitting too long. They take ibuprofen, they rest. Meanwhile, the underlying cause, stool stuck in the rectum, goes unaddressed for another 24 or 48 hours. If your back pain started around the same time your bowel habits changed, connect those dots. The third symptom, and this is the one that most people would never associate with a digestive problem, is confusion, agitation, or behavioral changes. Stay with me here, because this one is critical, especially for older adults and the family members watching for them. The vagus nerve, which runs from your brainstem down through your chest and abdomen, responds to pressure and distension in the gut. When the rectum becomes severely distended from impaction, it can trigger a cascade of autonomic nervous system responses, including confusion, restlessness, loss of appetite, and in some cases what looks very much like sudden onset dementia or delirium. In a nursing home or hospital setting, fecal impaction is one of the most commonly overlooked causes of acute confusion in elderly patients. If your loved one seems suddenly confused, agitated, or not themselves, and you haven't seen them have a normal bowel movement in several days, ask about their bowels before anything else. Ask. The fourth symptom is bladder problems, specifically the inability to urinate, or conversely, leaking urine involuntarily. The bladder sits directly in front of the rectum, and when the rectum is packed with hardened stool, it compresses the bladder and the urethra. Some people find they can't urinate fully and develop urinary retention. Others find that the pressure causes involuntary leakage. Both are commonly attributed to prostate problems in men or overactive bladder in women and treated accordingly, when fecal impaction is the actual culprit. This is what nobody warns you about. Your colon and your bladder are neighbors, and what happens in one affects the other. If any of this is new information, if you've never heard these connections made this clearly, go ahead and subscribe right now. Because what comes next, the action protocol, is what you actually need to do about this. Don't miss it. I want to be honest with you about what happens when fecal impaction is left untreated, because I want you to take this seriously, not out of fear, but out of respect for your body. In the early stage, the first few days, you have discomfort, straining, that sense of pressure that won't resolve. This is uncomfortable, but manageable at home if you act quickly and correctly. In the middle stage, typically beyond 3 to 5 days, the pressure on surrounding organs increases. You may develop urinary retention, significant abdominal distension, nausea, and loss of appetite. You may feel generally unwell in a way that's hard to articulate. Your body is telling you this has gone past the point of simple discomfort. In the advanced stage, and this is where things become genuinely dangerous, the prolonged pressure on the rectal wall can lead to mucosal ulceration, meaning the tissue lining the rectum begins to break down. In rare but serious cases, this can progress to perforation, a tear in the intestinal wall, which is a surgical emergency. Additionally, if stool becomes so backed up that it reaches the cecum, the beginning of the large intestine, it can cause a condition called stercoral colitis, an inflammation of the colon that can escalate rapidly. Here are the symptoms that mean you go to the emergency room now. Not tomorrow, not after one more attempt at home. You go now if you experience severe, worsening abdominal pain that is constant, not cramp-like, a rigid or board-hard abdomen that is tender to the touch, fever above 38.5 degrees Celsius or 101.5 Fahrenheit, rectal bleeding beyond minor spotting, vomiting that you cannot control, or sudden severe weakness, dizziness, or fainting. Any one of those, you go. Now let's talk about what to do, and I mean specifically, not vaguely, step by step. Step 1, hydrate aggressively, right now. Before anything else, drink 500 milliliters, that's about 2 full glasses, of warm water. Not cold, warm to hot. Warmth directly stimulates intestinal motility in a way that cold water does not. Do this first. Don't skip this because it seems too simple. The common mistake is sipping a cup of tea and calling it hydration. I mean 500 milliliters, deliberately, over the course of about 10 to 15 minutes. Step 2, gentle abdominal massage. Lay flat on your back, bend your knees, and using your fingertips, apply gentle but firm circular pressure starting at your lower right abdomen, where your ascending colon begins, and move clockwise across your upper abdomen, then down the left side. Follow the path of the colon. Do this for 5 to 10 minutes. You are mechanically encouraging transit from above, which helps relieve pressure even if it doesn't resolve the impaction immediately. Step 3, a glycerin suppository. These are available over the counter at any pharmacy without a prescription. They are safe, they work locally in the rectum, and they are your first-line tool here. Insert the suppository while lying on your left side. That positioning matters because it aligns the rectum with the sigmoid colon and makes the medication most effective. Then remain lying down for a minimum of 20 to 30 minutes. Not 5, not 10, 20 to 30. The most common mistake is inserting the suppository and immediately sitting on the toilet. The suppository needs time to soften the hard mass. Give it that time. After 30 minutes, sit on the toilet and allow, do not force. Straining against a hard impaction with great effort can cause hemorrhoids and anal fissures. And in older adults, the Valsalva maneuver, that bearing down breath-holding effort, can temporarily elevate blood pressure to dangerous levels. Step 4. If the suppository alone is not sufficient after 1 hour, a warm water enema, a plain tap water enema, not a soap suds enema, can be used. The volume should be approximately 120 to 240 milliliters. Again, left lateral position. Retain for at least 10 minutes if you can. The warm water softens and lubricates the mass from below while gravity helps encourage passage. Step 5. If you've completed steps 1 through 4 over a period of 2 to 3 hours with no result, this is your threshold to call your doctor or go to an urgent care facility. A clinician can perform a digital disimpaction, a manual removal, which sounds alarming but is a standard effective procedure done with appropriate lubrication and care. This is not a failure on your part. This is simply a situation that has gone past what home measures can resolve. Do not wait another 12 hours. Call. Type the number 2 in the comments right now if you're still with me and finding this genuinely useful. It helps me know this information is reaching people who need it. Once you've resolved an impaction, or if you want to make sure you never experience one, here is how you build a system that protects you going forward. Number 1, structured daily hydration, not thirst-based hydration. Because your thirst mechanism is less reliable after 60, you cannot depend on feeling thirsty as your signal to drink. Instead, set a schedule. 1 full glass of warm water first thing in the morning before coffee or food. 1 glass mid-morning, 1 with lunch, 1 mid-afternoon, 1 with dinner. That's roughly 1.5 liters across the day before you count anything else. The physiological mechanism here is direct. Water is the primary softener of stool in the colon. More luminal water equals softer stool equals easier transit. Number 2, dietary fiber. but with a critical nuance. Increasing fiber without increasing fluid intake can actually worsen constipation. Fiber works by absorbing water and adding bulk. If there isn't enough water in the system, high-fiber foods create a bulky, dry mass rather than a soft one. The counterintuitive detail: if you're severely impacted or severely dehydrated, increasing fiber immediately can make things worse. Rehydrate first, then increase fiber gradually, aiming for 25 to 30 grams daily from sources like prunes, oats, flaxseed, beans, and vegetables. Prunes specifically contain sorbitol, a natural osmotic agent that draws water into the colon, and have been shown in clinical studies to be more effective than psyllium fiber for chronic constipation in older adults. Number 3, daily walking. Even a 10 to 15-minute walk after your main meal of the day stimulates something called the gastrocolic reflex, the physiological response that activates colon contractions after eating. This is why many people feel the urge to have a bowel movement after meals. Walking amplifies that reflex. You don't need a gym. You need your own 2 feet and 15 minutes around the block after dinner. Number 4, medication review with your doctor. I want you to bring a complete list of every medication and supplement you take, prescription and over-the-counter, to your next appointment and specifically ask, could any of these be contributing to constipation? Don't assume your doctor has already considered the cumulative effect of everything on your list. They may not have. Opioids, iron, calcium supplements taken in high doses, certain blood pressure medications, and certain antidepressants are the most common culprits. In many cases, there are alternatives or timing adjustments that can reduce the impact on your colon significantly. Number 5, never ignore the urge. This sounds simple, but the consequences of suppressing the defecation reflex repeatedly are significant. Every time you feel the urge and suppress it, because you're busy, because you're not near a comfortable bathroom, because you just don't want to deal with it right now, the rectum gradually accommodates to being fuller, and the reflex signal becomes weaker over time. This is called rectal hyposensitivity, and it directly contributes to chronic constipation and impaction risk. When your body sends the signal, respond to it within a reasonable time frame. Number 6, a squatting position on the toilet, or as close to it as you can achieve. There is a real physiological mechanism here. When you sit on a standard Western toilet, the puborectalis muscle creates a kink in the anorectal angle, essentially putting a gentle bend in the exit pathway. When you squat or raise your feet on a footstool so your knees are above your hips, that angle straightens out, and stool passes significantly more easily with less straining effort. A simple footstool under the toilet is a $20 to $30 investment that makes a genuine, measurable difference. Now, I want to speak directly to the people who are watching this, not for themselves, but for someone they love, a parent, a spouse, someone they're caring for. Caregivers are often the first to notice the warning signs, and often the last to feel comfortable bringing up the subject. So let me give you something concrete to watch for. Watch for behavioral changes. Confusion, agitation, restlessness, or withdrawal that comes on relatively suddenly. In an older adult who cannot clearly articulate what they're feeling, a fecal impaction can express itself almost entirely through behavior. If they seem off and you can't explain why, ask when they last had a bowel movement. Watch for a change in appetite. A person with fecal impaction typically loses interest in eating. The fullness and pressure affect the whole digestive system, not just the rectum. If your loved one suddenly has no interest in food they normally enjoy, this is worth investigating. Watch for posturing, sitting forward, shifting position frequently, or seeming uncomfortable in ways they can't explain. The pressure from a rectal impaction is constant and can manifest as a general inability to get comfortable. If you suspect an impaction, offer warm fluids, offer to help with a warm abdominal massage, and contact their physician promptly. Do not wait for them to volunteer the information. This is one of the topics older adults are most reluctant to bring up, even with their own doctors, because of embarrassment. The conversation may feel awkward. The consequences of silence are worse. If you're a caregiver watching this for someone you love, type the word care in the comments. You are doing one of the most important and underappreciated things a person can do. Let me leave you with the things I need you to walk away with from today. Fecal impaction, stool stuck in the rectum, is not a simple constipation problem. It is a distinct medical event with specific causes, specific warning signs, and a specific course of action. It is not the result of not trying hard enough or not eating well enough. It is a physiological reality that becomes more common as we age, driven by slower gut motility, reduced hydration, medication effects, and decreased physical activity. The symptoms that mislead most people are the liquid seepage that looks like diarrhea, the back and leg pain that looks like a musculoskeletal problem, the bladder symptoms that look like a urinary issue, and the confusion that can look like sudden cognitive decline. Recognizing these for what they are is essential. At home, your tools are warm water hydration, abdominal massage, glycerin suppositories, and warm water enemas. In that order, with patience. If those measures fail over a 2 to 3 hour window, contact a healthcare provider. If you develop severe abdominal pain, fever, rigid abdomen, or significant bleeding, go to the emergency room now. And for the long term, hydrate on a schedule, not by thirst. Increase fiber alongside fluids, walk after meals, review your medications, answer the urge when it comes, and raise your feet on a footstool when you sit down. I know this is not a topic that comes up at the dinner table. I know most people have never had a doctor sit down and talk through this with them clearly, calmly, without rushing to the next patient. There is a lot of shame and embarrassment that surrounds anything to do with the bowel, and that shame costs people days of unnecessary suffering, missed warning signs, and preventable complications. You now know more about this than most people, and more than some clinicians take the time to explain. That knowledge is genuinely protective. If this video helped you, please give it a like. It helps this reach the people who need it most and don't yet know to look for it. If someone in your life is dealing with this, a parent, a spouse, a friend, share this with them. Drop a comment below and tell me, has this ever happened to you or to someone you care for? I read every comment, and if you want straightforward senior health education that treats you like the intelligent adult you are, without talking down to you, without alarm, without padding, subscribe. This community is exactly the place for these conversations. Take good care of your whole self, and that very much includes what's happening below the belt.